Good day, my name is Ola Alexander Christiansen, and I'm going to talk about the ventricular septal defect, also called VSD. And what is a VSD? A VSD is a septal defect of the heart between the septum, between the right and left ventricle, allowing blood to shunt from the left side of the heart to the right. This allows a large load onto the heart and lungs, which again increases the risk of developing heart failure, arrhythmia, pulmonary hypertension, and stroke. There are 4 types of VSDs, and the first one, which you see in the picture, is the outlet or conal one. This is the rarest form of VSD, which occur in the ventricular septum just below the pulmonary valve. The second one is the paramembranous, subaortic, conal ventricular, many names, same thing. And this is an opening in the particular area of the upper section of the ventricular septum, an area called the membranous septum, near the valves. This type of VSD is the most commonly operated on, since most membranous VSDs do not usually close spontaneously. The third type is the inlet or atrioventricular canal type of VSD, and that's a VSD associated with atrioventricular canal defect. The VSD is located underneath the tricuspid and mitral valves. The fourth one is the muscular or trabecular, and this is an opening in the muscular portion of the lower section of the ventricular septum. This is the most common type of VSD. A large number of these muscular ventricular septal defects close spontaneously and do not require surgery. There are some risk factors which are connected with this disease, and a VSD can occur on its own, but frequently tends to occur with other cardiovascular associations, such as tetralogy of Fallot, which is the most common cyanotic congenital heart condition, with many cases presenting after the newborn period. It has been classically characterized by the combination of ventricular septal defects, right ventricular outflow tract obstruction, an overriding aorta, and late right ventricular hypertrophy. Also mentioned truncus arteriosus, double outlet right ventricle, aortic coarctation, tricuspid atresia, aortic regurgitation, and pulmonary stenosis. Extracardiac association, such as aneuploidic chromosomal anomalies, such as trisomy 21, known as Down syndrome, trisomy 18, and trisomy 13. Other syndromic anomalies, there are several, and include the Holt-Oram syndrome. The symptoms. Symptoms depend on the size and magnitude of the left to right shunt. Children with a small ventricular septal defect are typically asymptomatic and grow and develop normally. In children with a larger defect, symptoms of heart failure, for instance respiratory distress, poor weight gain, fatigue after feeding, appear at age from 4 to 6 weeks, when pulmonary vascular resistance falls. Frequent lower respiratory tract infection may occur. Eventually, untreated patient may develop symptoms of Eisenmenger syndrome, which means that the previous shunt, which shunted from the left to the right, now is shunting from the right to the left. The diagnosis. The diagnosis of ventricular septal defect is suggested by clinical examination, supported by the chest X-ray and ECG, and established by echocardiography. If the VSD is large, chest X-rays shows cardiomegaly and increased pulmonary vascular markings. ECG shows right ventricular hypertrophy or combined ventricular hypertrophy, and occasionally left atrial enlargement. ECG and chest rays are typically normal if the VSD is small. The ECG, while small VSDs will remain electrocardiographically occult. Larger defects will classically demonstrate some of the following features: left atrial enlargement, high ventricular voltage, which are voltage criteria for left ventricular hypertrophy, prominent biphasic RS complex from electrode V2 to V4 with amplitudes more than 50 millimeters. This is also referred to as Katz-Wachsel phenomenon. The echocardiography Two-dimensional echocardiography with color flow and Doppler studies establish the diagnosis and can provide important anatomic and hemodynamic information, including the defect's location and sites and right ventricular pressure. Cardiac catheterization is rarely necessary for this diagnosis. And I wanted to show you how it sounds like in ventricular septal defect. So please listen carefully. So here is most prominent in the Erb's point, which is usually is. For the echocardiography, I want to show you just a brief movie of how it looks like. And it's described as a jet. The treatment is depending on the size of the defect. Small usually close spontaneously, larger may need surgical repairs. And the pharmacotherapy, either for stabilization of the patient before the surgery or for more prominent defects. So diuretics, digoxin, and ACE inhibitors may be useful to control symptoms of heart failure before cardiac surgery, or to temporize in infants with moderate VSDs that seem likely to close spontaneously over time. If infants do not respond to medical treatment or have poor growth, surgical repair is often recommended during the first few months of life. Even in asymptomatic children, large VSDs should be repaired, usually within the first year of life, to prevent later complications, particularly persistent pulmonary hypertension and pulmonary vascular disease, leading to Eisenmenger syndrome. Current surgical mortality rate is below 2%, and surgical complication may include residual ventricular shunt and or complete heart block. So, surgical closure of the VSD. Open heart surgery may be recommended if the ventricular septal defect is too large, if medications are not helping, if the function of the valves is affected, or if the child is beyond an age when ventricular septal defect may close by itself. During surgery, the surgeon opens the heart and closes the defect by using a patch for sutures. Occasionally, surgery may be recommended if the ventricular septal defect is not large, but is causing damage to the nearby aortic valve. This valve is responsible for keeping blood flowing out in one direction from the heart's left ventricle to the aorta. This may cause the valve to leak due to distortion of the valve leaflets. The outlook for the patient. The prognosis is good for small VSDs, which shows a high spontaneous intrauterine or postnatal closure rate. VSDs usually do not cause any hemodynamic compromise in utero due to the right and left ventricular pressures being very similar during that period. If large and left untreated, risk of Eisenmenger and cardiac failure is large. Thank you very much. These are my works cited.